How's everybody doing today? Where's Danny Scalise? Where in the world is Carmen? Was it? Not Carmen Miranda. That was the singer.
Carmen San Diego.
Carmen San Diego. I was gonna say Carmen Miranda, but I was like, that's not right. I know that's not right.
I'm in Georgia right now. I'll be in Florida tomorrow.
All right. I'm not even going to ask you what you're doing because it's none of my biz.
Nothing. I'm sleeping in. I'm eating too much. I'm enjoying this beautiful weather. You know, the kind of things you do on vacation.
There you go. All of that sounds good. And I think I think we're almost right on time. I wanted to apologize for folks for the late start, having to push the meeting back. We had an emergency call that I had to jump on, and so again, I just want to apologize and take a few minutes to get everybody situated. And then I think what we'll do is I'm going to start by introducing all of my friends and colleagues who've agreed to join me on this call. The first one is my brother from another mother, and that is Danny Scalise, and he's the executive director of the West Virginia Medical Association. And Stephanie Moore, who I bothered so much until she decided we were going to have a phone call so she could actually see who was pestering her all the time for all of these letters and seeking information. But her husband and I connected around telescopes. So Stephanie Moore, who's the director of the West Virginia State Office on Rural Health. And then Angela Hamilton, who's the executive director of the West Virginia and Virginia Pressley Ridge. And we know each other a bit, but not that well. So until I have a story, I won't try to make up one. So the first thing I think we want to do is, Danny, can you tell people what the West Virginia Medical Association does, what it is, what it's about?
Sure, Tony. Thanks for having me. So we are a trade organization, not unlike the Coal Association or Oil and Gas, but we represent the interest of physicians. And the physicians of West Virginia have said that they want to add patients and public health to their mission statement as well. So we kind of feel like we're one of the bigger lobbying organizations for public health issues on top of physician and patient issues.
All right. Okay. Stephanie, can you tell the people what you do at the West Virginia Rural Health Office? Oh, you're on mute. Okay, here you go.
I'm muted now. So I'm the director of the State Office of Rural Health for West Virginia, and this organization was put into place by a legislative executive order in 1990. And our mission is to implement programs and promote best practice models through collaboration with our stakeholders to address rural health care. So we operate a variety of federal grants through our office, and we are the agency that supports loan repayment for healthcare providers throughout the state, particularly in rural areas of the state. And we are also the agency that supports the critical access hospitals for our small rural hospitals in rural West Virginia. So that's a pretty broad stroke overview.
Okay, that sounds good. How about Angela? Can I call you Angie? Is that
yes,
okay?
Absolutely. That's what everyone calls me, actually.
All right. Okay.
Good afternoon. I'm Angie Hamilton Thomas, and I am the executive director with Pressley Ridge. Pressley Ridge is a social impact organization. We've been in existence since 1832. We originated in Pittsburgh, Pennsylvania, but expanded out. And we currently are operational in 6 states, including West Virginia. We touch the lives organizationally of over 8,000 children, youth, and families. In West Virginia, last year we served anywhere between 800 to 1,000 kids and their families. We provide innovative, cutting-edge services to some of the most vulnerable kids and families in our communities across the entire state. We provide community-based in-home services, foster care, treatment foster care, adoption, and residential treatment services, which are delivered on campuses in the state. So that's us in a nutshell, a very small snippet. I also have on the call with me Alex Cameron. He is the director of our clinical services, and Dr. Dennis Daley. He is under contract with us and has a wealth of knowledge and expertise in the substance use disorder arena. He is with the, up until 2020, he was with he just has a very impressive resume. He was with the Department of Psychiatry, Addiction Medicine Services at Western Psychiatric Hospital at the University of Pittsburgh School of Medicine. And he really does support our organization when we have issues with kids and families around substance use disorder and really around any clinical issues. So we are very fortunate to have him, and he is also on the call with us.
Oh, thank you. You all are so very impressive. I mean, in what your organizations do for West Virginia and what you all do. And, you know, I think I kind of want to throw out a question based on a call we just had. So in light of COVID, with HIV, viral hepatitis, substance use disorder, what are the gaps in the state? Where are people either not accessing COVID vaccination, or where are they not, and how are they not being able to access HIV treatment or viral hepatitis treatment? So I'm going to talk about it from a treatment perspective and direct medical perspective, but then I want to also talk about kind of the impact of this bill, SB 334. What are the policy and advocacy implications of that? And Stephanie, it's kind of also what are the resources we need in the state to help all of these people, right? Because we've got a huge problem. We have a huge hole. And part of the reason way you fix that, honestly, is through resources. So who wants to go first? I'm going to pick on Stephanie first because she's in my upper right-hand corner on my screen.
How do we move that? Well, I don't have all the answers to all those things, but I do know that in regards to vaccine nationally, there's been a lull, if you will, in the uptake of vaccinations in rural parts of the country. And I think that's true also in West Virginia for reasons we're not 100% clear of, but I do know the state's working on some specific communication models that speak directly to folks in rural communities in a way that maybe some of the communication hasn't done thus far. Also, in regards to viral hepatitis, I'm not sure if you're aware of a program called West Virginia HAMPS. It's a hepatitis academic mentorship program. So the State Office of Rural Health partnered with a variety of groups in West Virginia to bring a model that was used in Kentucky to address hepatitis C in particular. There were issues across Appalachia trying to diagnose persons, and then issues with treating them because in West Virginia, the Medicaid only paid for treatment if they had already progressed in the disease. And so there's a rating factor. You probably know this better than me. It's 0 to 4, I think, or something that way. Anyway, long story short, we brought this team together. They put together a West Virginia HAMPS model. WVU acting as the technical response of Dr. Feinberg. And we have pharmaceutical company that's providing the free treatment. And in the last year, they conducted, I think it was 4 trainings where they are training physicians on how to identify, treat, and prescribe for hepatitis C, and they cured 351 cases, I believe is the number from last year. So that's really, a partnership to help collaborate, and it's kind of off and rolling on its own. But if anybody needs additional information to the West Virginia HAMP program, I'd be happy to get you connected to that And that's really what the State Office of Rural Health does, is try to bring those partners together to address particular situations and then let them move out and act as a resource to connect you to what's going on that where they're at.
Wow. That's an amazing program. I think I had heard Judith Feinberg talk about it a little bit, but I don't know that she gave the overview that you gave. And so I think if we could probably get either a link to it, make sure we get it out to everybody that's on this call, so they'll know that that program is available. And so, Stephanie, will that mean that there'll be more Hep C providers in the state, that, or is it just more people that can write a script? Because we also have this issue, while they eliminated the fibrosis score, we still have the double PCR test. So, I mean, how do we get rid of that? And why do we even have a double PCR test?
That's a great question. That's one for Dr. Feinberg. The previous question, does it increase the providers? Yes. That is the entire goal, is to increase the number of providers who can appropriately treat hepatitis C.
Okay, very good.
I'll put a link in the chat box to our website, which will then lead you to the West Virginia HAMP program.
Okay, very good. I appreciate that. Thanks. And Marcus, can you just make sure we put that link on the list of things that we'll send out to folks after this meeting?
Absolutely.
Thank you. And now, Angie, what are y'all doing around Hep C or integrating hepatitis into your programs?
We don't really have a big issue with it with our kids. I mean, of course, if we had the issue come up, we would ensure that, you know, it was addressed. What we've done with the COVID vaccinations, we had, I mean, if you want any feedback on that, we have initially, providers had grave concerns because we really didn't feel as if we were being prioritized as children's providers to get vaccinations or have access to vaccinations as some of the other medical or nursing home folks were. So that was a huge issue in the beginning. And so it's been difficult for many of the providers. Pressley Ridge, we were very lucky, very blessed. We were able to work directly with a couple of the task forces through the health department to get our staff that wanted vaccines prioritized. So we were able to get that done. But other providers, weren't as lucky in doing that. So they're still trying. I believe some other providers are still trying to get their staff vaccinated. I mean, when you think about residential providers, especially who are 24 hours a day and in with kids, I mean, it was a huge concern that we couldn't get vaccines accessible to our staff a lot sooner than we did. So that was one barrier that providers really had to work with state leadership on. And we kind of felt like we had to kind of figure that out a little bit on our own. But we, I know that the state had some barriers they had to overcome as well with the way that some of the registration changed in midstream. So that was a barrier. Right now we're working on the kids that we're serving that are 16 years and older that want to have a vaccine. And we're trying to work with their, with their biological families, with their social workers, because most of the kids, or all of the kids that we serve outside of the community-based programs are in the legal custody of the state of West Virginia. So the guardian is the state, is the social worker. So we have to consult with the PCP, and we have to get if the kids have contact with the biological parent, we get the biological parent consent for the shot. The kid has to want the shot, and the guardian, of course, should be no reason that the guardian should deny that if the young person wants the shot. So we're working through that process now to get the access to the vaccinations for the kids that want them. So that's where we are with the COVID vaccination.
Okay. So, I mean, I want to kind of follow up on that. So do you think that the gap is educating either the foster or or the biological parent, or is the barrier that people don't understand that these kids are more vulnerable given that they're likely to, I guess, not be in a permanent facility or in a permanent home? And probably, no one's saying you have to wear a mask every single day. You have to, kind of consistently reinforcing that message. I mean, so I'm trying to get which one do you think it is? Which one do you see more?
Oh, as far as the gaps in the access, for us, I think it was just systems, the barriers in the systems. 1 minute we were down a path of, we were all registering through a certain portal. We were supposed to mark a certain, we were high priority. Then that changed. And then so I think a lot of times it just gets boggled down in systems. So I think that people kind of understand it's just the red tape, if you will, that we have to come up against.
Right.
And sometimes I just don't know. I think that sometimes our systems are overwhelmed, and we just deal with it. And that happens in a lot of different ways, a lot of different areas. So it's really our own systems that prevent us from things forward. And really it's just kind of that, it's systems.
Right. So Danny, I can you put your cocktail down for a minute, Danny? I know you're on vacation, but put the rum and coke down and tell me, if you can, what or where doctors or how doctors are seeing particularly barriers to access around whether it's COVID, vaccination, or viral hepatitis. Because right now, I mean, they've got to be on overload, right?
So Tony, I think I want to go back to your original question a little bit. And I think this is the same thing with physicians as it is with the general public. Education, and I found this out while we worked on Senate Bill 334. Education is something that we're going to need to do. The people on this call are going to need to do a little better in terms of talking to policymakers, physicians, because I assumed people with an education got it, and they don't. So I think we're going to need to talk to them a little bit about the diseases that we're advocating for treatment for. We're going to need to talk about the patient population and explain a little better who it is we're dealing with and why things happen the way they happen. Because I found that certain physicians don't get it, certain other healthcare practitioners don't get it, and policymakers certainly don't.
Okay. And so what should we do to educate these physicians? How do we get to them? Because, I mean, I don't know. Many of the doctors I know have a bit of a God complex and think they know everything already.
Well, that's what they teach them in medical school. That's a first year trade, is to get the God complex. So I'm sorry for any physicians that are on here. I work really hard for you all. But the reality is we're going to need to get to them at continuing education events, continuing medical education events for them. We're going to need to get to them through publishing things and sending that out to them, whether it's newsletters or papers in peer-reviewed journals. We're going to need to educate. And, I found that certain specialties are a little better than others at getting this, but I don't like all of family medicine. I had some family medicine physicians that approached me while we were working on 334. As they would read our newsletter updates, they would tell me, well, I'm against that. I think that's a bad idea. And I'd have to go back to them and say, well, the science is pretty settled. Let me talk to you about what the CDC says. Let me show you some. And after I would spend some time with that, but I can't one at a time, thousands of physicians in West Virginia, and we can't do that across the country. I think we need to do a better job mass communicating, talking to them and saying, hey, let me explain to you why we're taking the position. Let me explain to you why this works. And when we talk about harm reduction, I don't think everybody fully gets it. I think they've read some things in the papers and it's not as well articulated as I would like it to be.
But how do you get, I mean, okay, let's say all right, somebody opens up the gate and says, we've got all this money, Danny. Now we've got to educate these physicians. How do you legitimately do it? I mean, like literally, how do you get them to pay attention? How many read that newsletter? But can you get them in a room? I mean, you got COVID, so you can't get all.
Yeah, we got to get them in a room.
You can have some hybrid. I mean,
I think it's a hybrid. Hybrid is what it is, but we got to get them in the room. And I think we're starting to see that. Medical like ours, we do our annual meeting in August, and we just announced we're going to do it for real. We're going to go to a facility. And we've already got people registered. So people are looking for ways to get out and do things. We're going to take advantage of that. And Tony, I've talked to you a little bit about this, and we'll continue to talk a little more about how do we build that into our education platform for physicians? And then how do I get nurses and PAs to do the same thing? How do I get behavioral health folks? How do the psychologists build that into their continuing education so that some of these groups are better than others, but physicians as a whole, I don't think are as educated on the issues as I would like them to be. I don't think I'm as educated on some of the issues as I would like me to be. So I know that they're behind me in certain cases, and I'd like to fix that. So I think education is a big. I see Trina Scott sent me a message saying I really appreciate that. I'd love to do that because I think this is a way to get the word out, and I think you guys would be great to help out with that.
Yeah, can I comment on this from the point of view of addiction treatment?
Yeah.
With the opiate epidemic and the other substance use disorders, they affect tens of millions of people, and physicians and medical professionals are key parts of doing something. So for example, at UPMC, we paid for training for buprenorphine, medication-assisted treatment for opioid addiction, and so we had a lot of people who got trained in that. But when you drill down to the real world, what you run into is a number of things. You have some people that won't want to do it because they don't feel comfortable working with addicted patients or prescribing. But a lot of it has to do with resources as well. Physicians feel like, we have to do this, we have to do that. We keep adding things that we have to do. You don't take anything away. And I think we have to be certainly be aware of that. And the other thing is, for years, my program at Western Psych, and I'm retired from there, was closely associated with West Virginia University Behavioral Medicine. And you guys may or may know Dr. Rolly Sullivan was a big part of that. Unfortunately, Rolly, is recovering from a bad stroke, but he and his physicians and his staff did, I thought, a remarkable job throughout the state, not just West Virginia. I think they did things in Kentucky as well, teaching about medication-assisted treatment. And what they did is they helped reduce the stigma. You educate, but you have to reduce the stigma. But people need to have resources to help them do the work as well. So I think West Virginia has done a great job with addiction in terms of opiate use disorders. But the one thing that's missing, and I know more about some of the other states, so I could be off here. So my career was in addiction medicine. Running programs, doing direct service myself, research, teaching, all different disciplines. But with all the focus on the opiate epidemic and other addictions, the area that's been minimized has been the impact on the family. And the area that's been essentially ignored has been the impact on children. And since you are advocating for families and children, that's something you may want to look at. What's happening throughout the state in your treatment agencies? What are they doing for families? What are they doing for children? Because these diseases have a huge impact on the next generation. No different than many diseases run in family. Bipolar disorder, schizophrenia, cancer, diabetes. All these things run in family. So do substance use disorders. But I think, and I don't think it's unique to necessarily West Virginia. I see this throughout the country. So for example, you probably were inundated with all these reports on the opiate epidemic over the last couple of years, I'm sure. But if you look at them closely, how many talked about families and children? Probably very few. I mean, we had the Surgeon General of the United States do a report in 2017, didn't even mention children. And trust me, everyone, if you have an opiate addiction, you have children, they are affected. So that's something you may want to think about.
Well, thank you very much. And one of the things that I've been thinking about a lot is the rationale for how we do better engagement with our MAT facilities, whether that's around HIV, viral hepatitis, or COVID. Again, I think that those sites are unique opportunities for us to engage with those families. I think that to see it as an individual issue when they come to MAT program But I think from the organizational perspective, what we know is that roughly 30% only of West Virginia's medically assisted treatment facilities are reporting data on HIV, viral hepatitis upstream. And those data sets are really important because I think that they do drive often the funding that comes into the state and how the state is seen, and then what the need of the state is viewed. So I think that yes, we need to do more than what we've just been talking about. But I think that also one of the things that we can do is note that over 80% of the kids in West Virginia's foster care system right now, hang on, Marcus sent me a note. I don't want you to think I'm really this smart because I'm not. Marcus, now I can't bring the note up anymore.
That's okay.
You want to read it?
Yeah, absolutely. So, Katrina Harmon and I, who is also on this call, she and I grew up together. We have been very close friends throughout on the entirety of our lives. And we did an interview with her last year on our People Worth Knowing series. And one of the things that we discovered in her interview is that over 80% of the children that are currently in West Virginia's foster care system are there because of a drug-related incident, because of something involving substance use disorder. And if we extrapolate that out into additional disease states beyond just SUD, there are serious concerns that some of those children may have tragically been involved in trade for substances. And so that could expose them to infectious diseases. And I don't know necessarily that West Virginia has in place the screening, testing, or linkage to care infrastructure for juvenile patients that it does for adult patients.
Yeah, good point. Yeah.
Thank you, Marcus. Thank you very much. I think one of the other things that I want us to really kind of think about then is, again, what are the services that people are going to need to get through this? And, maybe, and I'm going to pivot a bit. It's an awkward pivot, but I'm going to pivot over to Danny about this first to lead us through this conversation a bit. Is that many of you know that Bill SB 334 has just passed. And Danny, do you want to give a quick overview of the bill and then talk about kind of the good, bad, and the ugly and going forward?
Yeah, I think the good of the bill is I and a lot of the people on this call and a lot of other people worked on it to chop away at it from the time it was introduced to the time it passed. And the governor still has to sign it, so it's not a done deal yet. But the good of the bill is it is going to put something around harm reduction programs and give a framework and tell people, hey, this is what you probably should be doing. And some of the stuff is best practices, but some of the things that were added on late in the bill, like adding an ID requirement and having a requirement that the county commission and the municipality approve of these programs was we felt a little harsh. And I think it's going to be a barrier for a lot of people to operate programs. So it is what it is. We're kind of sitting with it right now. I think the governor is going to sign it, even though there's a few people that are going to ask him not to. So we need to start working on messaging to providers to say, if you want to operate a harm reduction program, this is the environment that you're working in. You need to understand this, almost like a toolkit to say, this is how you operate under Senate Bill 334. So.
Okay. Marcus, is Bob on the call?
I don't believe that Bob Hansen is on the call.
Okay.
Go ahead.
No, I was going to ask you then. Marcus, do you want to talk? I know Danny just gave an overview, and Marcus and I have been arguing for a few days about this bill. So, Marcus, here's your time and your audience. How do you feel about this bill?
So, I think it's fair to say where we started in late February with Senator Tarr's initial version of SB 334 and with the version that came out of the Senate in March, one of the things that we're very concerned about is looking at how this is going to impact the existing services that are offered. One of the things that came out of the House version at the last minute was an amendment passed by Delegate Kayla Kessinger from Fayette County that Danny mentioned, that requires the majority approval, not just from the county commission, but also from any municipality in which they operate. So for example, that will have a long-term impact on the programs that exist in county health departments that are also co-located in cities. For example, Cabell Huntington Health Department operates their harm reduction program inside the Huntington city limits. And because of this, they will have to get new municipal approval from the city council, which they have, but they face a much dicier future in trying to get those approvals out of the county commission. And I think that this will be something that is replicated in other counties, particularly in Monongalia County, with MP Health, Milan Pushkar Health right up here in Morgantown. They have broad support from the City Council of Morgantown, but attempting to reach out to county commissioners has been essentially impossible to do. And Laura Jones explained to us on our meeting on Friday that attempting to get those people into a room to agree, it may eventually just end up shutting down all the programs together in the state. What that means in the short term, if we look at just Kanawha County alone, since the Kanawha County Health Department shut down their harm reduction program in 2018, we have seen a 158.8% increase in new HIV diagnoses just in Kanawha County, and a 134.6% increase in new HIV diagnoses in Cabell County when they restricted access to just Huntington residents. So this is a significant issue. And I do think that Danny's right. I don't think that, I think that if we pin hopes that the governor is going to veto this, I think our hopes are going to be a little bit dashed when it comes down the line.
Marcus, I think this is where this education is going to have to come in. Right now, I think there's a lot of people who've made a boogeyman out of these. This is the monster that comes out of your bed, like when you're a child, out of these programs. And the argument that people like Eric Tarr have made has been, if you let this come into your city, there will be increased syringe litter. They're going to do this. These people do that. And for the most part, the people who are making those arguments have never met a person at a harm reduction program, never seen one, wouldn't know what to do with it if they did see it. So I think this is where some of that, we're going to have to work harder to educate municipalities and county commissions and say, hey, let me talk to you about what really happens in this environment. Let me tell you what really happens when you do it right. And what's going to happen in your community is you're going to have less infectious disease, and there's going to be considerably more people that have an opportunity to get into treatment, because we're going to try to get them into treatment. And right now, those patients aren't seeing people. So too often we're catching them in Charleston. I'm on the Board of Health in Charleston. Too often in Charleston, we catch them in the ER when it's way too late. We haven't had a chance to even interject.
And that's actually a huge problem in the state of West Virginia. When we talk about not just HIV testing, but viral hepatitis testing, over 90% of all HIV and viral hepatitis tests that are delivered in the state of West Virginia occur either in emergency rooms or at county health departments. So if we're talking about a target population, people living with a substance use disorder, this is a population that is hard to reach and hard to treat at the best of times. Getting them into a county health department, where many of these county health departments sit across the street from a sheriff's department, they're very unlikely to go and access services in those areas for fear of being arrested. But more salient here is that when Senator Tarr initially started discussing this bill, he attempted to pass it off as a syringe litter bill. And what this bill will do is actually shut down the programs that are currently doing much of the syringe litter cleanup in the counties that have harm reduction programs. So once those programs are shut down, that essentially eliminates the syringe litter cleanup effort out of that program. So I believe the evidence has shown repeatedly over the last 30 years of harm reduction research that syringe litter actually decreases in counties and municipalities where harm reduction programs are active.
One thing is that people don't like the term harm reduction. They see it as you're giving permission to people to continue using drugs, which is really ridiculous. So you have that whole stigma thing. I just have you guys are big on education, which I think is good. But the way I think about this, and the perspective on this is decades in treatment and working in medical systems where we got our rear ends kicked by people that don't specialize in addiction because they want nothing to do with these patients, even though the patients are there. But the three key issues I see are attitudes among the providers, and we have to address that. You can do that through education, but you also have to do it through skills. If physicians and nurses and social workers, if they don't learn how do you deal with someone with a substance use disorder, they're going to feel uncomfortable. They're not going to do it. If you look at the national data, this is really sad. If you have major depressive illness or diabetes, you have a great chance of getting help. You know what the percentage of people with substance use disorders who get help? 10 to 12%. 10 to 12%. And the majority don't think they need they need help or want it. So the way we have to think about this is, how do we as professionals help people see they have a problem and raise the level of motivation to get them into treatment? Because there's treatment programs. The medication-assisted treatment for opiate addiction is very effective if people stick with it. It's the gold standard of treatment. But you have to get them into treatment, and you have to help them stay in the treatment as well. So there's some good things out there. It's just the biggest issue is engaging people and keeping them in.
Absolutely. And I think one of the other issues that we at CEG and here with the West Virginia Statewide Stakeholder Coalition have been attempting to focus on is increasing access. And that is kind of our goal. And not just access to treatment and services, but also access to educational opportunities, technical assistance, training, awareness. Our CEG's HIV-free WV coordinator, Amanda, has done an amazing job of putting together a relatively robust series of training and educational opportunities since the beginning of the year when we launched our TREAT initiative. And one of the things that we've seen is that behavioral health and mental health services specifically garner much more interest, particularly during this epidemic. The pandemic. And I think that we here in West Virginia, particularly through the WVSSC, have the opportunity, not just with CEG leading the way, but with all of the members of this coalition actually helping to provide the kind of training and technical assistance opportunities that providers need across the state. Tony, what do you think?
So I want to jump in here, and I want to jump in here and bring in Stephanie and Angie, because Stephanie, I'm wondering, like, at your level in the rural office, do things like the passage of a SB 334 affect your work, affect your planning? Do those type of things come up for you? And then I guess I'm going to ask Angie the same thing. It's like, a bill like this is going to impact families who, I think people have what they think drug users are, or who they think drug users are. But these are moms and dads, in many cases, and they get their kids to daycare. Sometimes, yes, they get their kids taken. They also get their kids to daycare and take their kids on the county fair, and I think people don't get this. So when a bill like this passes, does it impact you? Does it impact your planning? Or is it just like not our jam?
This is Stephanie. It definitely affects the work that we're doing and the direction that we have to go. And unfortunately, we're not in a position that we can affect too much of it, other than we share a lot of information with as many people as possible. We have multiple listservs, and so our objective is to get others who are in a position to stand for or against the bill to really speak up on our behalf, kind of unofficially. But we do understand, from the perspective of rural health, it's more than just access to care and making sure there are enough physicians in a community or in a rural county for West Virginia. And just as an FYI, West Virginia has 40 federally designated rural counties now. So we're almost a little over 2/3 of our state is designated rural. And we know that the impact of the opioid crisis and services to care have all impacted our families, along with social determinants of health of all varieties, right? Transportation, broadband, all those kinds of things. And one of the areas in mentioning children, I totally agree with that. In southern West Virginia, we have a huge amount of grandparents who are the caregiver for children. And there is someone brought this up a couple months ago, and it kind of struck me as, thinking forward, when these grandparents are elderly, these teenage children, these young adults are going to be tasked with, if they're capable, of taking care of their grandparents. And so we're going to see a reduction even greater than what we currently have in expanded education. I mean, how many of those, if they can even afford it, are going to go on to some sort of trade school or education? Maybe that number is going to be reduced because of the number that are going to care for the elderly. That's just something someone brought up on a call I thought was pretty interesting. But we try to pay attention. The State Office of Rural Health tries to pay attention to a variety of legislative issues that come up, and we watch a lot of them. So we're really kind of a bystander in the background, and then we try to adjust our programs to be useful where we can be.
Okay. All right.
I'd say our answer is very similar. I mean, we always have concerns when any legislation is passed that impacts the lives of those that we serve. It's true that, and I think that statistic now is more in the upwards of 85 to 90% of the kids that we are serving are touched in some way by substance use, whether they're in their own homes being served or in out-of-home care in some way, shape, or form. These kids are being touched by this epidemic. So of course, any kind of legislation that prevents or hinders access or programming that supports or helps families is a concern. We try to be active through our associations and try to have input and impact if we can in bills like this, and provide feedback and concerns. But we too have to navigate the best we can and continue programming and be flexible and nimble, and really try to support our families and find them resources when things like this happen. I think that, we try to keep our eye on, we're always normally through our associations, keeping our eye out on legislation and bills that affect children, youth, and family services, behavioral health services. We're always keeping a watchful eye out on those types of bills and legislation. And of course, if something concerning passes, we have to adjust and adapt and do what we can to still ensure that our kids and families are getting the best care, the best services, being linked in their communities the best possible, and be their advocates around that. So I think that lots of situations are difficult, but it's what we have to be there to do for those that we serve.
And your comment about advocacy is important. There's a lot of advocacy for mental illness, which is good. There's very little advocacy.
Okay, so hang on. So I want to hang on because I want to get in a couple other people before then. I want to jump to Robin, who's in North Carolina, because North Carolina just passed a pretty restrictive harm reduction bill I talked to Lee the other day, and he said that North Carolina's worried now that it will go the way, as he said, it will go the way of West Virginia. Have you noticed anything going on in North Carolina, Robin?
Not so much. This is really not an area that I do so much work in. So yeah.
All right. Well, I mean, you might want to keep your eye out, because what they tell me is that this train is getting ready to roll right through North Carolina as well. And I think that we're seeing it in particularly rural and southern states that are having impacted by whether it's a repeal of harm reduction rules or an increase of criminalization around substance use disorder and other things. So I just want to make sure that we are all keeping our eye out and keep on what can in fact happen in our local communities.
Hey, Tony, can I chime in on that real quick? I think this is important. I tell people this all the time. I teach health policy and advocacy at WVU, both the medical students and public health students. And one of the things that I tell them to do is to have a relationship with policymakers. This is important for all of us to do, not just the lobbyists, but for any of you all, because if you are the expert in this field, if you have some level of expertise, you want that policymaker, whether it's a state legislator or a U.S. senator, to think of, hey, that Tony Young lady, I need to talk to her because this affects the group that she's talked to me about. She's my expert on that. You want to be their expert on that. That's just to have a relationship with them and continue to have a dialogue with policymakers, whichever it is. Just find one that you can talk to regularly, and that will help out, because I've found that most of them, they don't know what we're talking about, and they don't have a lot of issues. So this one may not be their issue. We want to tell them exactly what's going to happen and what's what. And that's where it can make a difference, is if everybody is continually giving the same message to everyone in whatever legislative body we're talking to.
Well, Danny, I'm gonna push back a little bit, right? Because some groups who are, particularly those that are nonprofits, feel like, oh no, I can't do lobbying because I'm a nonprofit. I can't do advocacy. I'm a nonprofit. I don't want to mess up my nonprofit status. So are you telling these groups that they can pick up a phone and educate? Now, I'm making a distinction between lobbying and educating a member on an issue.
I think one of the things that they should be doing is, I don't care if you're a nonprofit or not, it's not going to hurt your nonprofit status to call and say, hey, Delegate such and such, hey, Senator such and such, do you mind to come down to my office and let me talk to you about what we do? I'm in your district and I employ 15 people, or I employ 200 people. Show them what you do. And that's your first in with them and your chance to talk to them about what you do and why you're the expert. And continue to invite them. If you do receptions, if you do things like this, invite them to come and talk and to hear from other people. And if you consistently have that relationship with them, I used to run a community action agency, and I invited anyone who represented our area to everything we did. And if we opened a new office, I had a U.S. Senator come in there to eat punch and cookies with me. And all the people in our community that we serve. And that's how I would build those relationships then. Never once. It doesn't, your 501c status is not going to be, this is not hardcore lobbying. This is just keeping that relationship with policymakers so that when your issue comes up, they think of you. You don't have to go to them at that point. If you get that good enough relationship, they'll think of you.
Yeah, I think we do a pretty good job of that across most of the provider community. We've had delegates and legislators actually attend some of our association meetings. We had major foster care legislation passed back in February. Last year, we provided lots of input into that legislation, concerns that providers had about that. And it wasn't considered lobbying, but was considered just education. This is really maybe people not being aware of unintended consequences of certain legislation that may go into play. There were things that were changed as a result of that education, but things that maybe not were, but I felt like we came out feeling much better about the legislation than what we did going into it.
You have a constitutional right, Tony, to ask for redress and assistance from your government. That's one of the most basic American fundamental things that you will find. So all of us need to use that to our advantage to make sure that our folks, the patients that we're there to care for, are the ones that are getting that same benefit, because they don't have high-powered lobbyists like coal mines or big corporations do. So with not saying anything bad about them, but a lot of the people we're supposed to treat don't have a lobbying group. So I like to use that tool of educating policymakers, because they don't have, the people that we're there to serve don't have a lobbyist per se.
Right. I see, and I guess I'm a firm believer in they don't have to be on your side, right? They don't have to agree with you for you to send them information about your program or to say what you need. They may never, ever, ever, ever say yes to you, but I think what you want them to know is that you're there, you're in need, and you're either in their district or in their county or in their state, or, I think that, that's really important. And so I think that, Stephanie, what would people come to you and say, other than I say, I need my letter, Stephanie, where's my letter at? And other than that, what do I call you and beg?
Well, most people, a couple different things. So we have a loan repayment program. So we get a lot of folks contact us about how do I participate in that program? How do I get my student loan debt paid off in exchange for working in a rural community? So we get a lot of that. The other thing that we get is, tell us where the grants are and how we get them. And so part of what we're trying to really strengthen our internal capacity with is really helping the community members to write those HRSA community level development planning grants so that they can get them. A lot of folks in West Virginia try to write them, but we're not very successful. So we're trying to really build up our team so that we can be more useful to the community when they're trying to provide that hands-on technical assistance. That people call us for information. We're working on a project A, and I need certain people, and so we try to know who's doing the zoo here in the government so that we can get you connected to the right people. That's predominantly what we do.
Okay. Doug, you had a couple of questions? Anderson, you still there?
Yeah, I'm still here. I just put a question in there. The Senate Bill 12 gave more power to county commissioners over actions taken by the local health department. So what's the impact there?
I'm going to turn that one over to. I'm going to turn that one over to Danny.
And I want to try and keep it in the context of your mission and vision, but a lot that's going on now are some of these counties and individuals going to try and turn back, smoking in public places and all of this good stuff that's for public health. Might not be popular, but now you've got decision making in the hands of non-health, non-medical folks that, quite frankly, have different interests. Or is this an opportunity to align public health, good public health policy with the county and get county leaders behind good healthcare initiatives? That's a challenge for all of us, and I think this group as well.
Danny, I see you came off your mic. Go for it.
Yeah, Doug. I think it's much more the former than the latter. I think what you're going to start to see is so we were able to get Senate Bill 12 so that it's not retroactive. So they can't go back and say we're going to take clean indoor air regulations and kill those. It has to be something going new. So if you are to open your clean indoor air regulation, if you're going to put that on the agenda, it can be. So I think the same thing goes with any other public health intervention that the Board of Health does. And I had a real problem with that. So did a lot of our other folks. I'm on a Board of Health. And when the county commission or the city council says something to me, I let them know that I am the expert. And they need to listen to what we have to say. So I think you're going to find some counties that are going to use these to lessen public health in West Virginia. They're really going to take some of these policy decisions we've made and try to roll them back. And there's ways they can do that under that new framework. I think there's some counties that it won't make a bit of difference too. So I think it just depends on county by county. And I think some people are going to be the worse off because of it.
You think? How do you see this? How do you see this as an opportunity for the health system at large, health and healthcare, as well as the social services? I mean, what is a way to get individuals that aren't as interested in health, although they should be interested in health, because health is wealth and security? How do you see this as an opportunity to get them more interested in the health of a community and individuals?
I think it goes back to the education portion. I think we need to look at county commissioners and say, hey, let me explain to you why it's good to have a Clean Indoor Air Act. Let me explain to you why it's good for you to have this. When you're trying to bring a company in here, if you bring it from an economic development standpoint, if I bring a company into a county and say, let me take you to this local restaurant, and we'll talk about it, and somebody says smoking or non-smoking, that company in most cases is just going to say, you know what, I've heard enough already. So I explained to them that rolling back those regulations is not going to be a good thing. So I think we're going to have to start working. And I'd love to see if there's anybody listening out there that's a nurse or a PA or a physician or a public health practitioner of any kind wants to run for county commission or city council somewhere. I will help you get on the ballot, teach you how to run a campaign. We need more people like that in office so that we can, and I don't care if you're Republican or Democrat, so you can just make some common sense decisions, things that we the people on this call, would consider common sense.
Well, all right. Does anyone else have any questions? Katrina, I see that you're looking very curious today. So do you have anything you want to add about kids or about kind of substance use disorder? Talk to us. You're going to be probably our last person. What do you want everybody to know? No pressure. No pressure.
No pressure. Well, I was going to say I would kick it back over to the professionals, Dr. Daley and Angie, that have much more experience working with the kids than I do, because my curious look is just absorbing all this. This is a ton of great information and very valuable food for thought as we move forward to advocate for children and families throughout our state.
Well, so I mean, I'm going to jump in with a quick question, both for Katrina and Angie and Dr. Daley. Well, what kind of technical assistance and training needs do you feel are needed for organizations to move outside of thinking of SUD and HIV and viral hepatitis as strictly an adult issue? What are the skill sets and skill building and issues that we need to start offering to providers to think beyond adults and start thinking about the impacts faced by children and families?
Well, and Marcus, let me add another piece of that. And where does ACEs fit in all this?
Where's what?
ACEs.
Adverse childhood.
Adverse childhood experiences. Yeah, Alex and Dennis, I'm gonna let you guys handle that one.
Yeah, about 7 of the adverse childhood events relate to substance use, incarceration, violence, and things that are very common in these families. I think a couple things to consider. One is your focus on education is good, but we have to take that a few steps further. The more you can involve people in recovery in your efforts, your work groups, your education programs, they can promote what's helped people with addictions and what's helped family members. We always include people in recovery in a lot of the things we do, and that makes a big difference. The other thing is, a lot of this, if you look at HIV and hepatitis and these things, a lot of these disorders are very high in the substance use disorder population. So the more you can attack that, you can get to these indirectly and directly. And the more you help the person with the problem, the more you indirectly help the family and the offspring. So you want to keep that in mind. Then the other thing I would say is that the best antidote for addiction, which is common causing these problems, is recovery and promoting recovery and mutual aid. There's a lot of mutual aid programs that make a big difference for individuals.
What do you mean? What do you mean by, Dennis? What do you mean by mutual aid? I want to make sure everybody's understanding what you're talking about.
Yeah, mutual aid programs like Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, Al-Anon, Nar-Anon, and then you have Faces and Voices of Recovery for families. These are support programs that help people. These are just people who volunteer and help each other out. And that's a very big factor. You know, so for example, in Western Pennsylvania, we have a program called Bridge to Hope, where family members help each other out. And sometimes people who've lived a certain way can help others in ways that professionals can't. But you need both. I think to attack these problems, whether you're talking about substance use disorders or hepatitis or whatever, you have to attack them from all these different areas. And I could tell you, you know, I was glad you brought up the thing about Hep C. I have a brother-in-law who's been very disabled by hepatitis C. I have a brother who had to get a new liver because of hepatitis C. So I've seen that in the family, and the despair, just the chaos, the pain in the family. It's a big issue, not just for the person who's sick, but the family members as well. So whatever you do when you think about this, you want to think about how can we help the family, how can we help children, how can we promote recovery, things like this, because professional services can't do everything. Legislation can't do everything. You know, we need to take advantage of what supports we have in the community that people can benefit from. And then the other thing I'll say, that there tends to be a pessimism about outcomes of addiction, but you may or may not know this, there's over 20-some million people in our country who no longer have a drug or alcohol problem who did. And there's a lot of people who do well, and they use a combination of factors, therapy, medications, programs, but the biggest resource they use are mutual aid programs. That's the most commonly pathway to recovery for a lot of people. Now, a lot of people need treatment in addition to that.
I think that one of the challenges, and hopefully I think we will probably do some either webinar about it or something, but we want to have a conversation about what are actual core beliefs, right? So some people believe that abstinence-based programs are the only way, and some people believe that MAT or treatment-based recovery programs are no way. And I think that we often don't talk about how those two planes and twains overlap, but intersect, but also run in conflict with one another for some people. And I think that it's an important conversation to have, because if we have people who don't see individuals who are on Suboxone or buprenorphine as being fully engaged in recovery, then what do they see them as? I think many people see them as people who are still using. I don't agree with that. But I think that it's an important conversation for us to have, because a lot of people do think that. And so, you know, with that, I want to take a moment to certainly thank all of you who've been on this call and who've joined us today. But I really do want to thank the folks that worked on this bill, SB 334. It was a roller coaster ride, but I have to say it was a group of people from very diverse backgrounds with varied interest in the problem. But I think the thing that everyone did have in common and remains to have in common is that they want the absolute best for West Virginia, and they want the absolute best for people who use drugs and their families in West Virginia. And we want to increase services and increase access. And I think the only way we do that is that we do it together, and we do it in coalition, and we do it in collaboration. So again, I want to take a moment to thank you all for taking an hour out of your day. I know that we are all zoomed out with the COVID, but you chose to spend an hour of your day on Zoom with me. So thank you very, very much.
Thank you.
Thanks, Tony.